Good afternoon, everybody, and I'd like to welcome you to today's webinar. My name is Kamini Gadhok, and I'm Chief Executive at the Royal College of Speech and Language Therapists. This afternoon, the subject for our webinar is an introduction to clinical business skills with a specific focus on children's services. Today, we're very happy that we have a number of speakers. They include Maria Luscombe, who's the chair of the RCSLT's Board of Trustees, and David Amos, who's the RCSLT's Workforce Planning and Development Advisor. Now, as I'm going to go through some of the aims of today's webinar, I just want to say I'm sure that many of you may have already heard David speak, either at the RCSLT conference or in one of the RCSLT Hub session. The focus of today's webinar is very much around the public sector and influencing, particularly in the face of cut and restructuring. However, we do hope that some of the information you'll be hearing you feel is transferable to other sectors. With respect to the learning, by the end of the webinar, we hope that you will have some appreciation of the key terms of clinical business, that you'll know how to use data sources to plan your service, have an understanding of the importance of business case writing skills, and appreciate the need to link aims to required outcomes. We also hope that you'll have an opportunity to think about how you show the cost benefit of your service. These are all very important areas of development, and of course we ensure that we review the learning needs of our members as we provide the support that you'll be hearing about. In terms of the webinar outline, we're going to have 45 minutes in total with presentations from Maria and then David, and there'll be an opportunity at the end of the presentations for some questions. If you would like to ask a question, please do use the Q&A button on the webinar software to submit a question for the panel. You may also want to make a comment, and you can use the chat button on the webinar software to do this at any time during the event. If you would like to tweet, then please use the hashtag clinical business as an opportunity to share any thoughts you may have with colleagues. The webinar is being recorded and will go online with the slides in about a week's time. So without further ado, I'd like to introduce Maria Luscombe.
Hello, I'm Maria Luscombe. As Kamini said, I'm chair of the Royal College Board of Trustees. I'm also a speech and language therapy manager in an acute and community trust in North West London. So I'm going to share with you today some of my experiences around data that is useful to make your business case. To me, data is one of the keys to influencing people. I think I'm using a quote from the Burkle Review, which I think is very relevant to gain an understanding of the needs of children and young people with speech, language and communication needs. So it talks about assessing and understanding the needs of individuals as well as of the population as a whole. That is integral to helping them achieve outcomes. And that's one of the things I wanted to stress, that we often focus very much on SLT data. And while that's important, it's equally important to know the population within which those children are and whom you have to provide services to. One of the key things, I think, is to develop a shared understanding of the needs of children and young people with speech, language and communication, and developing that with key influencers and local decision makers. So you may well want to think strategically about who you need to influence. For example, perhaps managers within your own organisations, some colleagues who may have powerful voices outside the organisation, such as community paediatricians who lead on children looked after or have a public health interest. You may want to share some of your information with health visiting leads or school nurse leads. Equally so, working with colleagues in the local authority or folk in the local authority who would be gathering information for the joint strategic needs assessments. And a very useful person I found in our local authority is the lead for performance, because they have huge amounts of information about local schools, local population that are very useful in building your business case. Often we don't tend to involve our staff perhaps as much as we should, and one of the things I've learned is that sharing those key messages with staff who are out there working in schools can also be quite influential, as schools and head teachers are more in commissioners than they have ever been before in terms of children's services. So let's think about local population. One of the best sources I've found is Public Health England's Child and Maternal Health Intelligence Network. And I've given you all the links to these at the end of my presentation. I do apologise at this stage to colleagues in Scotland and Wales and Northern Ireland for not being able to put up all of the links to them, but if you go to the RCSLT website, the links to similar organisations are there for you. But I think some of the key things I'm going to say applies regardless of whether you're in any England, Ireland or wherever. So first of all, you need to know a little bit about local demographics in terms of your population of children and young people. You need to think about population trends. Is the population of children and young people growing, or is it actually one that's declining, depending on where you live? Think about ethnicity and language profiles of your service users, both in terms of the needs of the parents and the families, as well as the needs of the children and young people themselves. I work in a very ethnically diverse borough where many of the children speak English, but many of the parents don't. And in order to provide good local services, you need to have a balance between both when you're thinking of your case. You also need to think about deprivation indices and the number of children that live in poverty. We know that there's a strong link between children in poverty and SLCN. Look at the health inequalities and look at educational outcomes. Now, all of these are available on the PHE website by borough, so it's very, very useful to have that look. Also try and find a copy of your JSNA. That's usually on the local authority's website somewhere, and also commissioning priorities for both the local authority and your local CCJ. The other thing that the public health data, and indeed data from DFE, will give you, again by borough, is the numbers of children and young people that the borough say they have with autistic spectrum disorder, behavioural difficulties, those excluded from schools, those in young youth offending teams. All will give you evidence about what you can expect in terms of demand for speech and language therapy. Also, if you work in an acute trust like I do, you can link with your colleagues in the neonatal unit, because they'll be able to tell you something about the survival of premature or low birth babies. We do know that there's a strong connection between that and children with developmental and speech, language and communication needs. Look at the education data as well, the results of the foundation stage for communication, language and literacy, the attainments of students with SEN, and of course the SEN and school census data sets. All of these are going to provide you with ammunition to make your business case. Then what you need to do is, when you've got this data, you need to link these quite clearly to at-risk factors for SLCN. And obviously, we are very lucky to have had the Better Communication Research Programme, because a lot of this data is there when you search through the Better Research Communication Programme. For example, gender, boys are often overrepresented to girls, but even more so with those with autistic spectrum disorder. We know there's a strong birth season indicator for SLCN. For example, those children born later on in the year, the summer child, are 1.6 times more likely to be referred than those born later on, are born earlier in the year, the older students. So have a look at your referral data. Are there schools who are referring you some of these very young children, and do you need to do some work with them locally? The BCRP also tells us a lot about social disadvantage, and we know that pupils, we can have up to 50% of children in areas of socioeconomic disadvantage with inadequate speech, language and communication skills on school entry. So have a look at your deprivation indices and your areas of deprivation, and try and link that to demands for speech and language therapy. Obviously, we know that poor socio-sensory or linguistic environments can also contribute to speech, language and communication needs. Again, looking at early years profiles, what's coming out of that may help you build a picture locally of who might need support. The other thing, obviously, is all the comorbidities that may happen, and thinking about that in terms of your local population. Again, link All of this to the impact of having SLCN, because obviously we know that children with SLCN are at risk of difficulties with relationships, poor attainments academically, difficulties with reading and writing, difficulties with poor behaviour. They can be excluded, they can be bullied. We know that some of those children end up in youth offending. So these are really strong links that you can make for local commissioners and build a case for speech and language therapy. We also know that there's national data out there around prevalence and incidence around SLCN. So I won't read through all of it on this slide because I'm sure very many of you are very familiar with it. So 1% of 5-year-olds entering schools in England have the most severe and complex needs. There are some frameworks out there, and I'm going to show you one of them. This is a framework, the Balanced System, developed by Maria Luscombe, and it quickly allows you to translate some of that data on prevalence into what it might look like locally, and is a very, very useful tool to actually use with your commissioners or indeed to measure yourself against. Marie has worked further with what was already the college position paper on children's services, and so this is strongly linked to that position paper, but obviously developed into the Balanced System, where she talks again about looking at the whole system approach to commissioning and indeed to supporting children with SLCN, which I've again found very, very useful in terms of speaking with commissioners. And again, if you look at the commissioning support tools which are available on CTC website, or if you look at the college position paper, or indeed Marie's work on the Balanced System, a lot of this will actually help you in building that business case. So I think also what you need to think about in terms of the impact on commissioning and service provision is this need to look at the very broad needs of children and young people, and where speech and language therapy in particular fits into that in that universal, targeted and specialist way. You need to look at local data around communication and family-friendly environments, particularly in the early years, because we know that it's very important to have early intervention, both in terms of early identification and support for children, but also early intervention when things perhaps are not going the way they should be in schools. You need to be talking to commissioners about the workforce, not just speech and language therapy workforce, but the workforce across children's services in terms of the knowledge and skills required by early years practitioners and school staff to support what you are providing. And you need to think about the speech and language therapist's role in the provision of universal, targeted and specialist services. And I found that view is certainly one that commissioners are welcoming. It does present us with problems in terms of trying to then say what speech and language therapy is required and translating that into workforce, but it is certainly something that commissioners both in local authorities and in health, and indeed backed by DFE, are thinking about in terms of that staged approach to provision. So what data sets do you need within your service? Obviously you need referral rates and trends, and I've talked a little bit about that. So do scrutinise where your referrals are coming from when you're getting them. Are you getting them early enough? Are there some referrals that you need to look a little bit deeper at and see, could they be prevented? Could they get to you earlier? You need to link with the areas of social deprivation and indeed the schools that perhaps don't do so well with children at the end of foundation stage, and talk to those schools and talk to your commissioners about how you might target those areas. Look and see, are you actually reaching the hard to reach groups locally? For example, locally we have a large population of travellers. How are we reaching those children and families, and can we prove it? Look at the age, gender, ethnicity and language needs, because they may vary very much from one area to the other. Then obviously some of the performance data in terms of waiting times for referral to treatment is important. Also the activity data in terms of what are you actually doing? What is your service delivering? Because if you are commissioned in that universal, targeted and specialist approach, it's not just about delivering one-to-one treatment or group treatment. It's also perhaps delivering training or support to parents or schools or teachers. And you need to find some way of capturing that. Look also at non-attendance rates and particularly what you're doing to resolve them, and obviously gaps in service provision. And although we're not focusing hugely on it today, service and user feedback is very, very important to have, and data around that. I'm not going to dwell an awful lot on SLT staffing because that's something David's going to take us in more detail into. But I think you need to think of the number, the grade, the skill mix, the competencies required to deliver what you are being commissioned to deliver it. And I think that's really important. You need to really hone down on what the model is you're being asked to deliver. And then from there, you can work out more about your clinical hours available, what you need, and the skill mix. And David's going to take you a little bit through that shortly. I have given you now 3 slides that have various resources attached to them that I think will be very useful. Those are Public Health England, obviously, some of your local authority and DFE websites, the Better Communication Research Programme, the Communications Trust, where you will find links to the balance system, to commissioning support tools, and to a very useful document around S&D reforms and a report on our February conference that was run jointly with the Communication Trust. You will also find a slide on the Child and Maternal Health Intelligence Network, and also the very valuable tools that are on the RCSLT website. Thank you. I'll now hand over to David.
Thank you very much, Maria, and good afternoon, everybody. My name's David Amos, and thanks, Maria and Kamini, for inviting me to take part in this session. I should pay tribute to speech and language therapists and all of you taking part today, that you have an interest in clinical business case making. I think that reflects extremely well on your profession, and the fact that you see the importance of making the most of resources, crucially, as a way of providing the highest quality of standards to patients and clients. So what I would like to do, in a second I'll introduce the main sections of my remarks, but before I do that, okay, so just a word about the programme I've been supporting with the Royal College over the last year and a half, and you'll see from my bio that I'm not a speech and language therapist, but I have worked in the NHS and related services for 25 years or so in general management and HR, human resources, and I've been the HR director of 2 London teaching hospitals and worked at a national level, particularly when we were growing the workforce at the turn of the century. And the programme I've been supporting your Royal College on has the strapline of understand, influence and control. And you'll see the sort of 3 key elements that make that up. And that's all about helping you as SLT practitioners and leaders get a greater understanding of the service and financial challenges that you're currently facing and the ones that are around the corner. And in turn, how can you get greater influence of decisions that are being made, and through that, therefore, get greater control of service development, which is going to be extremely challenging over the next few years, given those financial pressures, control over your working lives and your profession in order to promote value for money and provide the highest quality of SLT services. So greater understanding, more influence and control. And the slides that I brought together for you this afternoon give you a taster of the pack that we've been using in very different settings, at a training level, at a regional and national level across the UK, and with individual SLT teams. So over the next 14 minutes or so, I'd like to address 4 main themes. Firstly, the challenges ahead, which if I've got a Hammer House of Horror element, this is it. So hang on to your seats. Secondly, dealing with change, a few tips in that respect. Thirdly, which is core to the theme of today's webinar, which is how best to make the clinical business case. And that will draw very heavily and connect with the comments that Maria's just been making. And then to leave you with a few final thoughts on how you can build your own and the team within which you lead or work, its resilience over and through the challenging times ahead. So whilst I heralded my first section to encourage you to hang on to your seats, I'm sure none of you will have missed the fact that whatever part of education, health, justice, whichever part of the UK that you work in, that you already face and will continue to face very significant service and financial challenges. And I would say that that shouldn't leave us feeling there's nothing we can do. There remains massive opportunities. And I guess that's what underpins the point of this webinar, to help you take advantage of these challenging times in the interests of patients, clients, and your profession. This first slide that I've got is one hot off the press after the autumn statement which came out of the government last week. And it takes us, or the story, over the last going back to the late 1940s, after the initial birth of the welfare state, including comprehensive NHS and education. And the faint line, the lower line, is the one that reflects the amount of money that government has been able to bring in, mostly through taxation, as a percentage of the overall strength of the economy, known as GDP, gross domestic product. And the thicker line, the one above, is what government is actually, or has actually, spent. And as you'll all know, the ideal is to get the two to be the same. And if you want a surplus, to have more coming in than the amount that you spend. I think the big challenge for all of us involved in public services, if you look at the line going down on the right-hand side, 2018-29, is that it's going to drop very substantially as a percentage of GDP in order to get closer to the amount of money that government's getting in. And that's an issue for everyone who works in public service, not just those who work in the public sector. I've got a slide here that's been produced by the Nuffield Trust. It refers to the English NHS, but it's a story that you can read in any part of the sectors that all of you work in, and in any part of the UK. The crucial line to look at is, in the first instance, is the one that's sort of going steeply up to the right. So this is about a 10-year period starting in 2010. And that line going steeply up to the right, in terms of hundreds of millions of pounds, is the amount of money that experts have forecast the NHS needs in order to meet demand. Lots of debate about how to calculate that. The crucial one to keep your eye on is the one at the bottom, which is the amount of money being spent on the NHS, and you can see that's flatlining up until 2021. That will go up slightly given last week's announcements for the NHS across the UK, with some increase of £2 billion more per year. But that still leaves quite a gap, as you can see from the graph, and in particular with the 5-year plan for the English NHS. Again, a very similar story for all parts of the UK. The estimate is that the NHS needs £8 billion more per year by 2020. My third slide in this series looks at productivity. I guess this is my first introduction to some of the clinical business language, which I'll say a bit more about in a second. And this is a thing that politicians, leaders, the public, the media are interested in. Productivity is not just how much do we spend on staff and non-pay and how many people do we treat, but how well are we treating them. That's what productivity ought to be about. And it's something I know that you, as SLT professionals, are keenly interested in. What this slide says in terms of the story so far over the last 5 years, or so up until 2010, it's similar since then, is the extra money going into the NHS, which is the red line, is going up. And what the NHS does, the blue line, is also going up, but not much more than the red line, which means you then have a productivity index, which is the green one, which is fairly flatlining. And as we move into a phase where there's not a lot of extra money going into the public services, how can we find ways through skill mix, new ways of working, rationalisation, new systems, IT, in order to get more from the pound notes we spend, and in your case mostly on staff, with a small amount of non-pay, as it's called, the amount spent not on staff. My final slide in this first section, again an English view. We've got information that relates to Scotland, Northern Ireland, Wales. Again, a very similar story. And this is the number of SLTs, number of speech and language therapists. The red line is the number of you in terms of headcount, whether you're doing an hour a week or 37.5 hours a week contractually, at least in the NHS. And the blue is the whole-time equivalent, which is the number of SLT by 37.5 hours a week. And you can see that that's grown very significantly and has continued to grow in the last year, both in terms of whole-time equivalent and headcount. And that's a pretty similar story across the whole of the NHS in the UK. All of that at a time that the NHS is not receiving significant more income to pay for that. So that's some of the background in terms of the challenges. My next section addresses dealing with change. And this is very much part of the programme that I've been supporting the Royal College on, which is how to get a greater understanding of the changes as they're currently happening. Doesn't always make sense, as I know, to everybody, and more importantly, what could be coming around the corner. And we've collected together a number of observations, which is listed in this slide, and with some change in language in various parts of the UK or whatever sector you work in, whether you're in the public sector or if you're in social enterprise or the private sector, that these are the sorts of things that are happening wherever you work. Less cash, lack of clarity in a fast-moving scene regarding commissioning. We might talk a bit more about that in the last 15 minutes of the session, and major changes affecting all of you wherever you operate in public services, particularly the NHS. One of the things that we've been doing working with frontline SLTs, your teams, those who manage SLT services, is try to come up with a view of what your organisation could be planning. And this slide gives you a bit of a checklist that you could use to think through the sorts of things that could be happening. And I think the questions I would recommend you have are, what are the signs that any of these things already happening or likely to happening in terms of merger and procuring exercises, job evaluation and so forth. And if you can't see the signs, who might know within your organisation? And then crucially, what could it mean for your service? Just moving on in terms of how we all react to change, there are lots of very useful ways of describing the sort of reactions that individuals, leaders, teams have to change wherever we work, whether it's in our personal life or anywhere else. And I quite like this one from Peter Baron-Stark, which goes through a list of reactions to change, how employees, how all of us might react to change, particularly it's one that we're not expecting. Now, for some people, you can start with, not me, surely not me, and actually through a journey with potentially enthusiasm and a positive vision for the future. For many of us, we get stuck on anger and scraping around to find out who's in charge in order to work out what to do. I think this is quite a good checklist to think through, particularly when you work with colleagues in your team and elsewhere, to recognise how we all react to change, and crucially to work out how we get into a positive state. And by that I don't mean deluded, but positive in terms of what you can do to cope with change. My second slide in this series just lists how employers react to change. And I came up with this list as someone who's been on the board of a number of organisations facing the sorts of changes and doing things that affect the thousands of staff working in organisations. But often employers think that something is being done to them. It's often difficult to know whether to consult early without enough details and being criticised for that, or to consult later with more details and look like it's a done deal. Organisations often spend a long time checking that a major change really is as challenging as it feels, hence sometimes the silence, and that most organisations, the best ones, look at all options for change which do not affect staff in the first instance. And then to cap it all, if you're in the middle of a major change, why not try and sort out lots of things that have been on the to-do list in order to make improvements for the services, the people who use services. There's a list here on this slide of some of the clinical business language, which I recommend you don't need to become experts in, but to become familiar with. We're producing a glossary, which will be in all good bookshops soon, as in the RCSLT website, to help you get a better understanding of the language that others will use, so that you can at least be aware of what's going through their mind when they use it. And we'll be sharing that glossary shortly. Just a couple of slides here, which you can refer to during the seminar and thereafter, which is the sorts of things that organisations are looking to do when working out how to be more productive, how to get more from the resources, as I've indicated earlier on. And this slide talks about finding capacity to generate additional revenue, capacity to reduce spend elsewhere. Classically, that's in temporary staff or agency staffing. Capacity in order to enhance the service, particularly in a way that generates more income. And then ultimately, if that capacity can't be used, is to remove it as redundant. And the best employers will avoid redundancy to achieve that. And you can see from this next slide is the sorts of things that an HR director will have on their list when thinking through how to get more from the workforce. And as Maria referred to, the sort of things that I have on my list in terms of getting the data and information, this is the one that I use when I come and work with SLT services. I don't expect all organisations to have all of this information at their fingertips, but it's the sort of data that I look for as a healthcare manager to get a view of how effective and efficient, how well led a particular team is, and this then sets the benchmark for then moving forward. And then a question that the Royal College has been really in a pioneering position in terms of how best to develop the profession and make its contribution to a better value for money across public services. And these are the sort of 3 exam questions that I use with frontline teams to think through how best to deliver services. So what do I do that only I can do? What do I do that someone else can do? That can either be within the SLT team or elsewhere, as Maria's referred to. And then what do others do that I could do? And I think all of that helps individuals and professionals think through how best not only to make the most of our resources, but ultimately produce a better quality service as a result. And just as Maria referred to the wider team, not just members of the Royal College of Speech and Language Therapy, but who's in the team. And this graph shows the people in blue, all members of the Royal College, with all your high standards in qualifications and experience, who would call yourselves SLT. But who else is in the team? So the people in the green, support staff, could be nurses, could be teachers, could be doctors, all of whom are making a direct and indirect contribution to SLT services. And then crucially, particularly in your profession, those in red, non-qualified staff. So that could be the assistant level, administrative support, the IT technician, and other support, people who aren't on the payroll at all, parents, guardians, volunteers. I think all of this needs to be looked at to make sure you're getting most from the people who could influence positively or negatively the outcome for patients and clients. And in the tough times ahead, how to make the most of all these contributions in terms of delivering services. Just two more groups to my slides in my last minute. One is a reference to job planning, and it might be something that we come back to later on in the webinar. Basically what the Royal College has been leading on is how to make most of particularly the clinical specialist role in terms of job planning, which is a method that's been developed by the medical staff as part of their contract, the medical consultants, and how to deploy those clinical specialists. So this slide here shows you the sorts of people that could be involved in advanced job planning, which seeks to match capacity with demand, and focusing efforts on the crucial things that all of you are rightly professionally committed to in terms of having a positive impact on clinical educational outcomes. And what we've got in this slide is just an illustration, and Maria may say a bit more about this in our discussion, but looking at how you divide up your time between direct clinical care and supporting professional activity. You can see there are 4 categories here, and all of this is about seeing what you do with your time, how's that coordinated across the team. And when justifying relatively senior clinical roles that the organisation tends to focus on in tougher times, what that impact is in terms of the quality and efficiency of clinical outcomes. My final word is to just leave you with some thoughts on building resilience, a question I get a lot and have done in my career, and certainly in these tougher times, is what capacity and capability do I need to develop, particularly if I'm a busy qualified clinician and haven't spent much time getting involved in management and financial matters. And certainly the programme that the Royal College has been doing is about matching or closing that gap, giving people enough of the skills, helping you find time with toolkits and other checklists in order to be able to have a greater understanding of the challenges, be more influential and get greater control. You'll see in these 2 lists the best that I've seen, I think, in terms of things to think through, in terms of how you build your own resilience. And that's especially important if you're the team leader, because you therefore have a responsibility for the resilience of your team. And that doesn't mean rolling over and accepting all change, but working out how to encourage staff and colleagues and yourself to be able to get involved in change. And the challenge is, if you don't, someone else will take the decisions on your behalf. So there's a huge opportunity here. I know you're all highly motivated to do that. And another checklist here to leave you with. So thanks very much.
Thank you very much, David. And I'm very aware that David's had to canter through those last few slides. David mentioned that we may well go back to one of them, because one of the questions was about how do you evaluate the skill mix and integrate that with the required outcomes for the business plan. So I think if we could just go back up to this slide, which helps a little bit with trying to understand some of that thinking with respect to thinking about the sort of different types of skills that you might need in a team. David, can you help, and with Maria's support as well, about how managers and leaders might want to use this outline, and how some of our members already have used this as a way of trying to assess the skill mix in their team?
Well, briefly from me, because I think Maria would want to come in on that. So essentially there are 4 categories here, 2 that relate to direct clinical care. So what do I actually do in a hands-on way, and what do I do in support? And then SPA, supporting professional activity. So that's anything from being in meetings, doing clinical business case making, through to training and support. And where SLT services have been able to use this is to, and you can see in this illustration, is to think of an average typical week and look at how your time is split. And this enables you to look at it from your own personal perspective, and as part of a team, how that quite correctly could be different between individuals or the same. And crucially then, when justifying the resource that's spent on staffing, in justifying, making your clinical business case, is saying that this is the kind of split that works well and makes sure that patients and clients get the quality of support, either because what I directly do myself as a specialist and what I'm doing to supervise, support, train, audit the work of the wider team. Maria, did you want to add to that?
As David was talking, there was a couple of things coming through my mind. Obviously, the slide that David's put up here is a very good way of looking at the different aspects of perhaps how an SLT uses their time. One of the things I think that's really important in children's services is that into the direct clinical care, if you are being commissioned to deliver a more consultative type approach, which is indeed the universal targeted specialist approach, that it's not just the direct face-to-face work with children that needs to go in here, it's also the amount of time perhaps that a speech and language therapist will spend in educating or training the wider workforce around specific children or groups of children's needs, because that is in fact sort of the clinical care you're being commissioned to deliver, be it through a third party. So I've found this type of analysis very useful in terms of looking at how not just clinical specialists spend their time, but also perhaps how our band 5, 6s, etc. spend their time. You know, if you're delivering a community service like we do, you'll also want to add in things like how much time do you actually spend traveling, how much time do you spend on the phone, and all of those things can help, I suppose, convince David and others who would be looking at us from a workforce perspective, actually justify how we're spending our time and what we're doing. But I think into that mix, we need to think about what are we trying to deliver locally. So we've talked a bit about the model of services, but also what's the demand locally. So in my team, we work across acute and community. So one of the things we perhaps have developed locally is a dysphagia service for children that runs across acute and community, because that's what we're required to do. So if you looked at my service in comparison to a service who perhaps just delivers community services, we probably have more dysphagia type specialists than in other areas. So I think you do need to have all that stuff that I just talked about in terms of what's the local caseload like, what's the local demands, and translating that into, okay, what clinical specialist posts do I need? What's the complexity out there, and how do we go for that? Also, in terms of sort of skill mix, what we've looked at is our packages of care. What are we actually offering to children and young people out there? What types of package of care are we offering? How much clinical time needs to go into those different types of packages of care? And although it's not a scientifically proven fact, we can actually say, well, we've delivered X number of packages of care that in general would take up X number of hours of clinical time. So it is a bit of an analysis, but I think we do need to do it to show and to prove to ourselves and to others we're making valuable use of our time.
Thanks very much, Maria and David. We had another question which linked to this particular table, so I'm hoping that we have responded to that, which was about professional activities such as clinical supervision and outcomes, and how you might include that in your business planning processes. Other questions that we had that we haven't yet responded to, one of which has come in from Simon, which is how can members of the SLT NHS workforce at band 6 and below contribute to and develop skills in clinical business?
Great question. I guess there are two principal routes. One would be a more formal route in terms of there are tons of courses, accredited or otherwise, and certainly I would recommend the ones that organisations provide around budgeting and staff management, even if it's not something you're doing in the first instance. If nothing else, it will give you a sense of whether that's something that you're interested in and give you some of the practical skills. I mean, my sense is the best thing is to sort of get involved, and there are a number of SLT teams who've got people at band 5, certainly band 6 level, who are taking the lead on various aspects of their clinical business work. It could be on looking at new ways of working, marketing, and various other elements. So get involved in project work. I know time is very precious, But I think that's probably one of the ways to get stuck in. And I think if nothing else, will give you a sense of where it's something that grabs you. But frankly, everyone's going to have to get involved in this as they get more senior in order to be influential.
Hello, Simon. I'd just like to say I think it's a very good question. And just locally, how we've used Band 5s and 6s is around delivering on clinical audit. Our needs assessment, we very much involved our Bands 5s and 6s in looking at needs within their local schools, nurseries and other areas. I think the other thing that you can greatly help is in things like giving voice campaigns or increasing awareness locally about what your service does. To me, each and every speech and language therapist out there in the workforce has the power to influence, whether it's in their nursery or whether it's in their school or whether it's with their parents as service users. So I think there's lots of ways that you can get involved, but getting involved in a project group or in a clinical audit and looking at how you deliver services, questioning that can be the start of getting involved in terms of business skills.
Thanks very much. That's great. Now, we're just coming towards the end of our webinar. We have had a few other questions which we will be able to respond to by email, some of which I hope we have responded to as part of the webinar and the discussions that we've had. And of course, we would welcome any other comments or questions once we go offline. Just to remind everybody that we will be putting the slides up from this webinar in about a week's time. And just to thank both Maria and David very much indeed for all their time today and for all of you joining online. Thank you very much and goodbye.